Let's talk about the timing of your reconstruction. So there are a few terms you'll hear thrown around when it comes to timing. There's immediate breast reconstruction, where one step of the reconstruction is performed at the same time as the mastectomy. There's staged immediate reconstruction, which is where the reconstruction is performed 2 to 3 weeks after the mastectomy. There is delayed immediate reconstruction, which is when a tissue expander is placed at the time of the mastectomy, and that is exchanged for a DIEP flap a few months later when the tissue expander is removed. And then there is delayed reconstruction, which is when your breasts are reconstructed at a date months to years after the mastectomies were performed. So immediate reconstruction is appropriate when we want to put something in your body or complete some stage of the operation at the time of the mastectomy. And I like to kind of step back a minute and ask ourselves, what are we actually accomplishing when we do this? For example, a lot of people like to put in tissue expanders at the time of the mastectomy and exchange them 3 months later for implants. I've done that most of my career. It's the most common way breasts are reconstructed. However, I think the tissue expander is an unnecessary step if we don't need to stretch out skin. Meaning if you are going to have enough skin after your mastectomy, there is no reason to put you through tissue expansion and place tissue expanders. Because tissue expanders, like any prosthetic device, have a risk for infection and other complications. So if we can skip that because it's not really solving any problem, we should skip that step. So if you don't need to have any skin stretched out as part of your reconstruction, what I recommend that you do, and my preferred way to do the reconstruction, is to have you get your mastectomies. I would mark you for the mastectomies, tell the general surgeon where to cut, and so I'd see you in clinic before your surgery, either days, a week before. I'll draw on your body, I'll give you markers, you take the markers with you to redraw the markings on you until surgery. The general surgeon will then use my markings to do the mastectomy, and they will leave as much extra skin behind as we need to do your breast reconstruction. We then let your body heal for a few days, let the drains from the mastectomy come out, let the skin live, and then 3 weeks later, you're already on the schedule. 2-3 weeks later, we go back and I go straight to implants and we're done with your reconstruction. In other words, we skip the tissue expander phase. So if we don't need to stretch out your tissue for any reason, there's no reason to put you through a tissue expander process and the risks associated with that. The reason that I like to delay the implant placement by 3 weeks is because it allows me to make sure the skin is going to live before I put in the final implants. The most common complication of breast reconstruction is a mastectomy complication, meaning the skin after the mastectomy doesn't live. If any of that skin along the incision dies due to lack of blood flow, the underlying prosthetic reconstruction with tissue expanders or implants may become exposed and infected. And that is the most common complication of all of breast reconstruction, is infected implants and infected expanders. And it usually starts with the mastectomy incision not healing very well. And so my preferred way to do a breast reconstruction, if you want to use implants, is to have the general surgeon perform your mastectomy, like I said, let your skin heal, let everything go through its normal healing phase after the trauma of a mastectomy. And then by the time we go back 3 weeks later, we will know what skin is going to live and die, and the fluid production around the implant will be far less, which means the drains after the reconstruction can come out way faster than they could if I did the reconstruction at the time of the mastectomy. And the faster the drains come out, the less likely it is to get infected. So by waiting those 3 weeks after the mastectomy, what we get is a cleaner space to put the implant, healthier tissue around the implant, and the drains do not need to stay in as long, which means the risk for an infection around the implant is lower. So that is why I like to do the staged immediate technique if you're going to have an implant reconstruction and if you don't need to have any skin stretched out. In other words, the tissue expander step is an unnecessary step in that process. Now, if you need to have skin stretched out, then we should put a tissue expander in at the time of the mastectomy, and we'll keep our fingers crossed that all of the skin lives on top of the tissue expander and that the tissue expanders do not get infected. If you're going to require radiation, and you want an implant-only reconstruction, I would do the staged immediate technique, whereby you have your mastectomies and 3 weeks later I put in implants and you're done. And then you get radiated after that. That would be preferred. If you want a flap reconstruction and you need to get radiation, I would put in the tissue expander at the time of your mastectomies and let the tissue expander hold that pocket open and function as a somewhat breast reconstruction during the radiation. And then we would return 6 months after your last treatment of radiation to take out the tissue expanders and do the DIEP flap reconstruction. If you do not need radiation and you want flap reconstruction, then I would recommend you do the mastectomies initially, wait 3 weeks, and then we'll do your deep flap operation. I really believe that if we can skip the tissue expander when it is unnecessary, it really helps reduce the number of surgeries and complications that you have with breast reconstruction. I find that most of the complications with breast reconstruction, both myself and in the plastic surgery community, are problems associated with the devices shortly after the mastectomies. And so if we can separate that initial mastectomy phase where there's a bunch of inflammation from the mastectomy, there's poor blood flow to the skin on top, there's a ton of fluid being produced due to the mastectomy and oftentimes the nodes that were biopsied. If we can separate that out from a prosthetic device initially, it significantly reduces the risk for infection and other complications associated with an implant-based reconstruction. It also reduces the complications with a flap reconstruction because the skin on top of the flaps is less likely to die. Now, if you want to have a deep flap reconstruction and you'd like to do it at the same time as the mastectomies, that is an option. And in that case, what I would do is I would use a special camera called the SPY camera to tell me what skin after the mastectomy is going to live and die. And whatever skin the camera tells me is not going to make it, I'm going to cut out and throw away, and I will make up for it using your belly skin. The advantage to waiting 3 weeks, though, is that your body's stronger, the skin is stronger, and we know what skin is going to live and die for sure after 3 weeks. And so then it is much lower risk to proceed with the reconstruction at that time. Now, some people are going to criticize that. The staged immediate technique is what they do at Duke. And in my own experience, I've found that it's easier on the patients and has a lower complication rate, again, because we are separating the mastectomy operation, which is not a clean operation and leaves poorly perfused tissue on top of a device. Why is the blood flow poor? Well, most of the blood flow to the skin on your breast travels through the breast tissue. The breast tissue is cut out at the time of the mastectomy, and those blood vessels that feed the skin of your breast are cut out as well and transected. And so the blood flow to the skin on your chest of what's left behind is way lower than it normally is. Over time, even over 3 weeks, the blood vessels expand and grow, and the blood flow is much better 3 weeks later than it is initially. The other point I want to make is at the time of a mastectomy, I don't think it is a sterile wound because all of those breast ducts that get cut at the time of the mastectomy are full of bacteria. And when those ducts get cut as part of the mastectomy, those bacteria pour into that pocket or that wound. If there's nothing in there, then there's really nothing to get infected. If there's a tissue expander or an implant in there, they can get infected. So you combine the fact that there's bacteria from the ducts in the breast that spill into the wound, we can't see it, but I'm sure it happens, with decreased blood flow following the mastectomy, increased fluid production, and a prosthetic device in that space all at the same time, and there is a significant risk for infection. Spacing it out 3 weeks dramatically decreases that risk. So, in summary, immediate breast reconstruction. In summary, based on my preferences and what I find works best in the Pensacola community, is if you want an immediate breast reconstruction at the time of the mastectomies, you either should have tissue expanders placed for future radiation or future deep flaps, or you should have an immediate DIEP flap reconstruction where I can use belly skin to make up for whatever skin looks bad on your chest at the end of the mastectomies. The other option is if you want an implant reconstruction or you're willing to wait 3 weeks for anything, get your mastectomies. We do no reconstruction at that time. We let your body heal a little bit, let the skin rebound a little bit, and then at 3 weeks later, we go back and put in implants all in one stage or deep flaps all at one stage. If you're gonna need radiation, I would prefer to do one of two things. Either have your mastectomies done and 3 weeks later we put in implants and you're done, and that way after radiation no one has to hopefully operate on your breasts and make an incision on that skin that doesn't like to heal. Or if you want flaps, we put in the tissue expander at the time of the mastectomies, and 6 months after you finish radiation we go back, take the expanders out and put the deep flaps up on your chest. Now, the reason I don't like to do deep flaps before radiation is we don't want to radiate those flaps. Radiating the implants or expanders is fine, but we really don't want to radiate those flaps. So I hope that makes sense when it comes to timing of breast reconstruction. I know it's confusing, and that's why in our visit we will break it down further and figure out what is best for you. To learn more, check out our website where you can upload your photos and concerns as a virtual consult. You can also check out our price estimator to get pricing information for all the various procedures we offer. And finally, if you'd like to have your questions answered on a future podcast or Q&A video session like this, please leave a message on our SpeakPipe. You can go to our blog page and our SpeakPipe is located there. Thanks for listening.